Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record, and also please remember to fill out the program evaluation. And the CME committee is always interested in hearing any ideas that you might have in regards to future topics or future speakers. Our speaker today is Dr. Nate Noble. Dr. Noble is a pediatrician and a geneticist. He did his pediatric residency at Blank and then did a developmental pediatric fellowship, followed by a genetics fellowship at the University of Iowa, then returned to Blank. He is an adjunct assistant professor in pediatrics at both the University of Iowa and at Des Moines University, and he is here today to update us on genetics and primary care. And please join me in welcoming Dr. Noble.
Thank you. All right. Just for the chocolate milk, I mean, it's worth the trip. You guys know what you're doing up here. For sure. Okay. All right. So, great. Let's get started. Okay. So again, my name is Nate. I work at Blank Children's Hospital in Des Moines, and we do two kinds of medicine. We do developmental behavioral pediatrics, and we do clinical genetics. So our wait list is long. We're limited by a lot of different factors, including age. So I apologize if some of you are out there going, I referred somebody to that guy and his clinic said no. It's only because our wait list is so ridiculous that we just have to find some way to parse it out. So I apologize if you're angry. You can punch me after the thing. Maybe if I come back with a black eye, they'll hire a partner, right? Okay, so let's get started. We're talking about genetics in primary care, okay? So oftentimes when I meet people, they'll say, oh, okay, cool, so you did developmental pediatrics? Well, that's so interesting. Why did you do clinical genetics? And then I tell them the story of Wayne Gretzky. Wayne Gretzky, when asked how he scored all the goals, it was because Wayne Gretzky was a guy who wasn't where the puck was. He was where the puck was going to be, right? I mean, if you haven't figured it out already, genetics is going to be your problem. This army of super geeky people led by people like me are going to be crashing into your office talking about whole exome sequencing and copy number variation and pharmacogenomics and haplotypes and all these things. And oftentimes, no matter what insurance companies want to try and pretend is happening, this is real. I mean, this is all very, very real. I know I don't have to convince a lot of you, but when I think about insurance companies, I have a lot of convincing to do. So, I have nothing to disclose. It's truly a miracle that anybody pays me to do anything. All right? Now, I put the highlighted portions of the talk in pink. And the reason I did that was because pink is kind of a happy color. So if I was coming to a town that had a football team that was struggling, I would use pink. Okay? I'm with you, folks. I am for you, not against you. All right? I trained in Iowa City, and I ran out of that town as fast as I could run. So I'm for you people. Okay, let's do this. Okay, so we're going to go super quick through history because you don't need to know this, okay? But what I want you to understand is that there's lots of years that go by when we start figuring stuff out, and then you get to 2002, and the whole lid just blows off this mother. It just goes crazy. In 1866, you got a guy who had a lot of time on his hands figuring out something about peas, right? And that was Mendel. Okay. In 1953, you got Watson and Crick, and they do something about this double helix going in different directions, craziness. 1959, we figure out that if you have too many chromosomes, that's not necessarily a developmental enhancer. Okay. If it's the 90s, we start realizing that it's not just big changes like extra or missing chromosomes, but it's pieces of the puzzle, like books within a library. If you turn out a page, you rip a page out, or you replace it with another page, something bad happens. 2002, we complete the Human Genome Project, and that's when this whole thing explodes. We have what's called a comparative database. I can tell you what a typically developing person's A, C, T, and G nucleotide at position this, at protein this within their genome. It should be in a typically developing person, and when you match it up with people who aren't typically developing and you see discrepancies, now we start to implicate genes, and everything starts to go crazy. So what I tell folks is that, genetics is an exciting field of medicine to be in. There's new stuff happening all the time. But more importantly, the common genetic conditions are going to touch you wherever you are in medicine. I mean, just look at the prevalence. 1 out of 800 children in America has Down syndrome, right? An extra chromosome 21 or an extra portion of chromosome 21. Congenital heart defects, right? Congenital heart disease, 1 out of 100 people. 1 out of 100 people, right? Cystic fibrosis, a recessive condition, sickle cell anemia, you can see 1 out of 600. I mean, these things are touching everybody's lives. And these are just the big ticket, low-hanging fruit kinds of things. They're not even the new stuff that's coming out every month where we're talking about new syndromes and new copy number variations and new gene deletions and duplications that we didn't know existed. And the impact from 0 to 5, this is the largest cause of mortality. Like, think about the kids that you've cared for in the hospitals or in the clinics that have passed away, right? I mean, the bottom line is there's a lot of gravity to understanding what is the cause of a child's strengths and a child's weaknesses. What is the cause? What is the underlying cause for their health-related concerns? 2 to 3% of newborns have at least one major congenital anomaly, right? 2 to 3%. And I remember I did general pediatrics, and I was like, I just couldn't do this. I'm like, I cannot do this. First off, I got way too much ADHD to make this work. I got to get out of here. I got to go to something else, right? But then the other thing was that I couldn't handle the idea of sending a kid out of the newborn nursery and knowing that, man, 2 to 3% of those kids are going to have something major. Yeah, they don't have a heart murmur now, but they will, right? I mean, that's scary stuff. And this is, it has a lot of impact. 2% of newborns have a chromosomal abnormality or a single gene disorder. So my clinic is busy. All genetic clinics are busy. Okay, so the next thing I want to talk to you about is I want you to understand the role of the primary care provider in genetic medicine, okay? Because it's not just about referrals, right? I'm not here to drum up more business. No way. I mean, if I can defer referrals, I'd be doing myself and probably you a favor. But what I want you to understand is that we all have a part to play. I think we're entering into a season of medicine, right? Where the medical institutions, the subspecialty providers, the clinics, the institution itself has to become less. And what we're doing in communities, what we're equipping families to do, the services that we're equipping them and educating them to provide have to become more. Because 17% of children in America have a special health care need. And there's not a lot of people that are lining up to go into developmental pediatrics. It's not a very exciting field. I think it's awesome, but most people want to run away. So there has to be ways to think about this differently, and I think that story starts with you. So here's your role, okay, from my perspective, because I want to make sure I understand my audience. I want to talk to you not just about complex changes and technologies that don't relate to your clinic practice. I want you to understand how the field of clinical genetics matters to you on a daily basis and is not just in referral. Here's where it starts. Family history. Oh, I got to tell you, I was like, oh man, I can't tell too many stories here. I can't tell too many stories, but I have to tell you one. Super important. So I see this child. I was in Des Moines for like 15 minutes. And I'm in Des Moines. I'm in this clinic. I'm by myself. I've left the academic centers. People tell me I'm a maniac. They may be true. That may be true. And I see this child referred for Marfan syndrome. Okay. Now, Marfan syndrome, these individuals tend to have a lot of musculoskeletal changes, arachnodactyly, long fingers. They have cardiac malformations. They have a lot of they have ocular findings. This is a dominant condition within a family. I walk into the room and I see this short, stout little girl, totally healthy, no structural abnormalities at all. And I'm just thinking, oh, this is great. This will take me 5 minutes, right? I start asking family history. Everyone's like, nope, we don't know. We don't even know why we're here, Dr. Noble. We're not really sure, which is awesome when you're a specialist. And in comes the dad about halfway through the evaluation. The dad sits down, right? Looks like a lot of the guys I grew up with in my hometown in Northwest Iowa. Just this rough and tumble, kind of just missing a couple fingers, beer for breakfast kind of guy, right? I totally grew up from, that's where I totally came from. And so I'm like, I get this guy. So I go, hey, we're just talking about family history. You got any family history? You a healthy person? He goes, yeah, I guess. And then I go, what do you mean you guess? And then he says, when I was younger, I had my entire colon removed. Okay, that's odd. I mean, this guy's younger than me, probably. And I said, well, what was the problem? He said, oh, I'll tell you what the problem was. The problem was I had a bunch of polyps in there. So they had to take out the whole thing. And then I sat back and I said, that's interesting. Did it have a diagnosis? And he said, yeah, it was some diagnosis. I don't remember what it was. And then I said, was it called familial adenomatous polyposis? And he said, yes. Now that's a dominant condition, right? So 50-50 inheritance. So the girl that I'm seeing in front of me, turns out, no, she doesn't have Marfan's, but she does have FAP, right? You don't get that colon removed, you don't start doing screening exams, that's a death sentence. Those babies are going to turn cancerous for sure. She had it, her sister had it, the whole family had it. Family history. Family history is a genetic tool. I use it not only to decide what kinds of genetic tests to conduct, but to determine what is not worth my time. Is it worth chasing down an X-linked condition here? X-linked cognitive impairment, right? I mean, there's panels. I could spend $6,000 in 3 minutes, right? Probably not a good idea because X-linked inheritance is never going to be transmitted from a father to a son. Likely dominant. Let's do this. I promise that this won't be painful. I promise. I just took my genetics board, so I'm like all hopped up on this stuff, right? I have to prove to you that genetics is actually something that it's actually important. Okay, it's more than pedigrees, by the way. Now, okay, so what's this one? Let's take a show of hands. Here's what we've got. I'm going to talk it out and give you some lobs, all right? You got a dad who's got a problem. He's blue. He's got a blue problem. He transmits this to some kids, right? To this kid who circles mean girls, squares mean boys. He transmits it to this kid, and then those kids go on to transmit it to their kids. You see male to male and male to female. You see it in every generation. What do you think the inheritance pattern is here? Autosomal dominant. Good. Gave you the lob. Love it. Okay. There's a lot of common conditions. Neurofibromatosis, achondroplasia, osteogenesis imperfecta, Marfan's, right? Hypercholesterolemia. How about this one? It just appears. It's almost like it's got lateral transmission. Everybody's healthy. Boom. Now I got 2 kids with the problem. What do you think this one is? It's recessive. That's right. So each parent has to be a carrier. You got 2 children with a recessive condition. Each parent is an obligate carrier, right? Cystic fibrosis, sickle cell, PKU. How about this one and this one? They go together. You got healthy dad, healthy mom. Boom, I got a son who's got a problem, right? Son gets married, had some kids, no problems. His daughter goes on to have a kid, and boom, oh no. Now her son has it, right? How about this one? Because they're the same kind of idea. Mom's got it, passes it on to some kids, passes on to sons and daughters. Daughter's got it, passes on to her daughter and her son. Her son has it, but only passes it on to a daughter. No sons. These are both X-linked. X-linked dominant, X-linked recessive, right? So the point is not do you know pedigrees. The point is a family history as I'm able to elicit in the clinic or from your notes helps me clearly understand what kind of disorders are in the differential and what kinds of disorders are not at all on the table, right? So the role of primary care is much, much bigger than you think, in just as it pertains to family history. There's other inheritance patterns. We're not going to talk about them because they're really painful to think about. But that's kind of where I come in. But the role of a primary care provider starts with family history, and it also goes to physical exam, okay? Because believe it or not, I read your stuff. I read your developmental screens. I want to know who's doing what up here, who's doing the ages and stages, who's doing the peds, who's doing the MChat, what are they doing with the results, right? Because you folks got the same problem we have. You don't want to screen too many people and get a bunch of false positives. You don't want to screen 0 people and never refer anybody for early intervention. You got to find that middle ground, right? And so I read these things, and I also read your physical exam, because I'm going to walk into a room and look at a child, and I'm going to want to know, did you see the same things I'm seeing? So let's do another test. What's Jay Leno's problem? Problem's a strong word. Problem's a strong word, okay? Because I've got some stuff going on that, it is what it is. What's Jay Leno's thing with his face? His chin. Okay, what's the matter with his chin? Okay, chin haters, chin judgers, what's the matter? Does it look like your chin? Anybody's chin you've ever seen in your life? No, right? That's huge chin. It's gigano chin. How about this beautiful lady? Now, here's the thing. A lot of supermodels, very dysmorphic, right? There's something that's just not right about some of that stuff that we're seeing. Let's take this beautiful, I don't even know her name. I don't care. But let's just check this out. What do you notice about her face that's maybe not like most people's? Her eyes are a little bit closer together than I would guess most people to be. She has a fairly prominent nasal bridge with upslanting palpebral fissures. Her eyes, if I measured her palpebral fissures, I bet they're big, right? So she has big eyes, right? She has a very prominent, this is called a columella, right? And very large lips, okay? Look at this guy. Look at this guy. This guy, it looks like, and again, I'm not picking at him. I'm just saying I can find something wrong with everybody in this room. And wrong's a strong word. It's not like you're so wrong. That's what I'm saying. What I'm saying is that everybody's got something that makes them them, right? Just because you got a unique thumbprint, you got a unique face print, okay? Now, this guy's got a pretty unique face print. It almost looks like somebody took his eyes on his head and just squeezed them right at his head, I call that, he has bitemporal narrowing. And when he smiles, the girth of his smile is broader than his head. Like, that is impressive, right? Okay? How about this dude? This is a lob. Look at this. You could keep a wallet in there. And I'm not making fun of him. That's just the truth, right? And these are people, most people would say are beautiful. And I agree. They're all beautiful people. This gal, look at how deep her nasolabial folds are. Right? That does not look like most people does it? So, physical exam, dysmorphic features, these are things that land in your office first because they're going to generate for you clinical suspicion. Now, what I want to show you is some ideas on what you can do with these findings because just seeing things for the sake of seeing things isn't helpful to you. I want to help you. So here's what I want you to think about. You're in the newborn nursery. You see a baby who's got one minor malformation. And I'm going to explain what I mean by that in a minute. But they've got one thing on their body that you can look at and say, I don't think that's quite right? Let's say it's a preauricular pit. Let's say it's a fifth finger clinodactyly, which is a turning of the finger. Let's say it's a shortened limb. Right? Let's just say something that doesn't quite fit, but you don't know if it's isolated or not. Well, the good news is if a child only has one of those things, the likelihood they're going to have a major malformation is pretty low, right? So it's less than 5%. But let's say they have two minor malformations. Now they've got low-set ears and wide-spaced eyes, something like that, or like a cleft lip, or, that'd be more of a major. But let's say some other kind of minor finding, something that just doesn't make you feel quite right. Well, the good news is, even if you got two of those, you're just over 10% likely. So you're 90% likely not to miss something horrible, which is good. But you got that 10, 12% that worries you. But look at what happens when you get to three minor malformations. All the way up to 90%, right? I mean, that's pretty scary. That comes out of the back of one of the more popular genetic textbooks. Very popular concept to get across that I try and share as much as I can. So when you think about minor malformations, I want to quantify that for you. Now think about things like 2-3-toe syndactyly, right? So like my dad has that, whatever. Hypertelorism is the wide-spaced, or hypo, meaning kind of closely spaced eyes, preauricular skin tags, epicanthal folds. These are things that likely in and of themselves, as their standalone findings, are meaningless to us, right? They don't mean anything. I tell families there's hard findings and there's soft findings. Absence of the corpus callosum, not helpful. Does not help me. I probably don't have a corpus callosum. Who cares, But there's sometimes you do care, but most of the time, these are kinds of things, fifth finger clinodactyly, these are things that don't always help me narrow my differential, right? Major findings, everybody knows. Cleft lip, cleft palate, congenital heart stop, brain, omphalocele, limb abscess. I mean, these are obvious major things, right? But an aggregate sum total of 3 or more of these babies, you got to go on a hunt for these guys, okay? And I'll explain a little bit about what I mean by hunt. So let's just look at a few basic things, again, just to kind of give you to bookend this. So you have some kind of way to think about major and minor problems. And sometimes it's just fun to go through these things because it helps you be like, oh, that's okay. I always thought my mother-in-law looked strange, but okay, now I get it. I got it now. She has this, okay? That's one nice thing about me is that the nice thing about genetics is that you can very clearly explain why somebody doesn't look quite how they should, or you think they should. Cupid's bow, okay? Now, a Cupid's bow is this. Look at this. Look at this. It's a bow, right? It's a bow and arrow. I'm going to shoot you with a love dart because I love you so much. That's what a Cupid's bow looks like. This is what a Cupid's bow looks like when it's absent completely, right? So these are called paramedian peaks, and this is called the median notch, right? That's our thing about genetics is that we actually have to give names to all these ridiculous small features on the face so that I can, do that. So that's what that is. That's an absence. This is the presence of an exaggerated Cupid's bow, right? What's wrong with this photo? What do you think the minor malformation is here? How many teeth do you usually have in the front? Just most of us have 2. It can be very subtle, right? This is very concerning for an underlying growth hormone abnormality and midline defect of the brain. You're going to want to make sure there's not a submucous cleft here or even a clefting of the uvula. Like, you got to be real suspicious when these kids come through. He's going to have hypotelorism. His eyes are going to be close together, I guarantee it. You're going to do an MRI and you're going to be blown away by some form of lissencephaly or something. And then this is, so that's a single central incisor. And this is a high, narrow palate. Now, here's why that finding matters to me. Because what I'm trying to do in genetics is not just narrow a differential. I'm trying to figure out, does it fit with the family history? Does it fit with the physical exam? And does it fit with timing? Because how do you develop a high arched, narrow palate? It becomes less arched and less narrow when you move your tongue in a sucking fashion in utero. When you don't do that, something was going on 6, 8, 10, 12 weeks gestation that probably was genetic, right? Some kind of genetic condition that was manifesting itself that early, right? So that's why I care about high arch palate, because it gives me an idea of timing. Okay. The periorbital region. So let's talk about eyes for a minute. Okay, and again, I'm not trying to give you an anatomy lesson here, but just to give you a few concepts. Some of these slides are really for your reference. Ideally, a lecture should not have, 55 slides. It should have, 10. But, I want to equip you with things in my absence. Hopefully they'll be useful. So what I want you to understand here is that where the eyes are placed matters. Now, this is a typical distribution or a normal setting of the eyes, right? So you got your pupil, and then you got this what's called the intercanthal distance, right? The outside of the iris doesn't really butt up against the intercanthus, right? You've got a nice white spacing there. That tells me that unless things look very abnormal, this is probably somebody who's got normally spaced eyes. But when you look at telecanthus, these are kids that you're going to see in your clinic, and they look like they have wide spaced eyes, but they don't. They don't, because what's happened is their intercanthi, which is this kind of crease and this kind of crease where like the eye comes through the kind of that creasing there. What it is those are wider spaced than they should be. But if you measure their interpupillary distance, look, it's the same. They don't have hypertelorism. That's not what that is, right? Sometimes you have hypertelorism, meaning you've got a widened intercanthal distance and you've got wide eyes, right? And sometimes you have wide eyes and telecanthus, which is this long, wide spacing of the intercanthal distance, which is beyond what you see in this picture. And then they really look like their eyes are on the side of their head. Like it really, really looks like that. Here's a few more photos just for your reference. I threw out some in here that I thought were kind of useful. One I really wanted to highlight to you. The rest of these I'll leave for reference due to time. I want to understand, this is what an almond-shaped eye looks like. I had to Google an almond to understand this. Because, you hear this term thrown around all the time. And what it means is, as the eyelids come towards the midline, they kind of take a dive. They go, whoa, right? I'm coming, whoa, just like this. I'm coming towards midline and wham, down I go, right? Epicanthus inversus is when you've got this extra flap of skin that kind of comes up and around. You've seen kids like this. It can be a very normal finding. Blepharochilasis is what happens when you got old appearing eyelids. Some of you are like, I have blepharochilasis. I do too. It's okay. It means you're awesome. It means awesome. Hands as well. This is fifth finger clinodactyly. This is camptodactyly, meaning I can't flatten out my fingers. And this is one example of ways that the palmar crease can be abnormal or bridged. or almost a single palmar crease, but it's a little bit bridged in this example. These are just some basic examples of what minor malformations could look like. I could talk for 2 hours on minor malformations, but I just wanted to give you a sense as to what I mean by that. Okay? So the role of the primary care provider, as we kind of shift into, we'll say, almost fourth gear in the talk, is going to culminate with a referral. All right. Now, again, I told you, I meant what I said. I'm not trying to generate referrals per se, but I want to make sure that you know that that's obviously a piece of the puzzle for you, but I want you to use family history and physical exam to kind of decide who really has a high yield, who is a high yield referral and who is maybe we can watch and wait. Because, I mean, in my clinic, it could be 6 to 9 months. At the university, it could be 6 to 9 months before we're going to be able to lay eyes on kids. So referral and medical home. So just even if they come to somebody like me, we make a diagnosis, I'm still going to see them back and help kind of manage the long-term issues in terms of pulling the research, seeing what's new, seeing who needs to be involved in this team. But they're still going to need that basic level support that I know you folks do an excellent job of providing. But I wanted to give you a few tips, right? Because I'm trying to put myself in your spot. I'm a busy pediatrician or family practice doctor. I got a kid that's going to be a good referral, lots of minor malformations, kind of a spooky family history, and some, some health-related concerns that are relating to those things. So people ask, well, great, Noble. So I see this, and you come and do this thing, and I refer this kid, and so awesome. So now he's 6 months old, and he sits on your wait list, and what am I supposed to do? Am I just supposed to give him shots? What do I do here, right? Here's what I want to tell you. And I am shocked at how few people take me up on this. I'm saying this tongue-in-cheek. It's going to go south as soon as I say this. But I like it when people call me, okay? Because I don't know if I'm just old school on things, but like recently I tried to give up a few things, like just to kind of change my lifestyle. One of the things I tried to give up was meetings. I just thought, I'm done with this. I don't need to do meetings anymore. There's no need. I'm not going to do email. That's another thing I tried to give up. These both blew up in my face, right? But I'm just kind of old school in that I'd rather just, if I'm going to meet with people, I'd rather have it not be a meeting, but have some value, know what I'm here to say, what are we here to talk about. And email is just kind of a waste. So I like it when people call me. Like I've had some great calls from folks up here. You guys always have smart questions. They're always well thought out, and they help me know when I need to break my referral rule. Because here's what people think. I'll just write some stuff and then send a bunch of stuff through the scan, and they'll know what I mean. And we don't know what you mean because those things come all day long from all over Iowa. And so the first thing that I like to hear about, if I say no to you and you know it should be a yes, you call me. You say, Noble, listen, this is what the situation is. I know this kid's 17. I know you don't see 17-year-olds, but he's a Sudanese refugee. He's never seen anybody in his life. I suspect it's this, or this, based off this, or this. Will you see him? And then I will always say yes. And my staff, they just go nuts. They're like, "Arr!" Every time my phone rings, they're like, dang it. He's going to break all the rules. But I like it when you call me because then I'll call you back and I'll tell you what I think you should do, right? There's things you can do while you wait. You can do developmental testing. We'll say screening. Forget testing. We'll even lower the bar. You can do developmental screening. You can do an ages and stages. You can do an MChat. You can do all kinds of different things that will help me outline the strengths and weaknesses of the child, and you can generate referrals. It really makes me sad when I see kids that have been on my wait list for 6 or 9 months, and then the family comes in, and I'm like, tell me about what services you're getting, and the family say, we were just waiting to talk to you. I'm like, what? No. Early intervention, area education agency. The schools can provide these services. You know as well as I do, they're not perfect. They don't get everything that you want. You have child serve here. They'll take private insurance. They'll take Medicaid insurance. I mean, you've got Fort Dodge. I know maybe if you get some bleed over from that side of the state, they've got Highland Park that will take Title 19 in private. These are groups that will love your referrals and will help you help these kids. I really get frustrated when I'm making these referrals. And thankfully that's happening less and less. You can also, depending on the nature of the child and the physical findings, I can help you understand based off embryology and just general developmental types of concepts in genetics, what kinds of pan scans you should consider. I'm not going to do an MRI on every child you send me. Okay, I'm just going to put the crowd at ease. I don't usually need that information. It's not usually useful to me. but there are things that I will do fairly routinely. If there's any semblance of a midline defect, I will always do an echocardiogram only. I don't need a cardiologist necessarily on the front end to read that. I just need it done, okay? I like to do a renal ultrasound because the kidneys seem like they are super weak. Those things will take a hit. I mean, you just look at those things, they start bawling, you know? Skeletal survey, depending on the age of the child, because I need to know, are there additional skeletal problems? Midline deformities often involve segmentation anomalies of the spine, butterfly vertebra. Sometimes MRIs and CTs, but albeit that's rare. Ophthalmology is the cheapest, kind of brain study that you'll ever get from my perspective. I want to know what that retina looks like. I need to know because sometimes I'll see kids that have got spotting or changes that are consistent with a certain genetic syndrome, so they almost always involve ophtho. And please, if you think of it, have their hearing tested. You only have to see one kid referred for a genetic evaluation who doesn't turn when you call his name, and the reason he's having trouble in school is because he's deaf. Right? And I wish that I would tell you that never happens, but it happens. So just be thinking about those things. And then lastly, do the best you can to work with your staff to get me the records I need. If you're worried about a child who's having growth failure, please send the growth charts. If you're worried about a child with microcephaly, I'd love to see the head circumference measurements from your office. I know you're like, well, no, duh, of course. You would be amazed at what people don't send me, and I have to call and ask for. Emergency situations. This is only for your review. I'm not going to go through this, but if I were you and I was up here and I was trying to figure out what to do, and I got a baby who crashes with hypoglycemia that's non-ketotic, and you're like, oh my goodness, this might be a fatty acid oxidation disorder, and you don't even get the newborn screen sent or you don't get the results back, and the child has died, it's okay to pull this slide or call me on the phone, and I'll tell you what I'd like you to do before that child goes to, say, the funeral home. There's some studies that we could do that would be very helpful for the family. Thankfully, the University Division of Genetics, Metabolic Genetics is awesome, and they'll also help. Okay, so here we go. We've only got about 15 minutes to go. We're going to come right out on time. And so we're probably in 4th gear now. Okay, it's only a 5-gear car, so just in case you're bored. All right, understand the role of genetics in healthcare, okay, and the technologies utilized therein. I'm not going to tell you everything about every genetic test, but if you understand a few basic things about the current technologies, you will be privy to understanding how things are done and why things are done to a much greater extent than perhaps you are now. Okay, so I want to talk to you a little bit about, and as I get into that, that'll be more in the diagnosis part. I want to talk to you a little bit about the role of genetics in healthcare in general. Now, you already know, and I've already alluded to the fact, that the Iowa Newborn Screening Program is important, right? This is where genetics is especially valuable because it allows us to prevent bad things from happening. Almost all the kids that we would see when I was at the university with metabolic conditions, they were almost all detected on the newborn screen. And so it really allowed us literally to see these kids' lives go from, near death to doing great. So the story really is best exemplified in terms of prevention with a newborn screening program in the state. Diagnosis is what I want to talk to you about now, and this is kind of where I come in, okay? So I see a kid that you referred, and let's say they've got all kinds of different, they could have any number of different things, but one thing they're almost all going to have in common is they're going to have some level of developmental delay. Okay, sometimes they have intellectual disability, right? And so I'm going to step into that evaluation by conducting a few kinds of tests. But I want you to understand, before I talk about the tests, I want you to understand what types of mechanisms cause disease in general, right? Because if you start there, then you understand why I do this, and I don't do that, right? So the types of genetic mechanisms that cause disease are chromosomal. Okay, so I got too many chromosomes. I don't have enough chromosomes. I got an arm of this chromosome that's broken off and stuck over there, and this one was stuck over here, right? That's an example of chromosome. That's like the karyotype kind of idea. But then there's Mendelian inheritance patterns, which involve single genes, okay? Now, single gene disorders can present with mutations, meaning somebody just tore a page out of that book or flipped it around or put another page in that doesn't belong. Those are harder to see. But oftentimes, if you've got gains or losses of genetic material that are in the same zip code as important genes, then that also gives us an idea that we're talking about a single gene disorder, but it's because it was broken or deleted or duplicated. So if you understand the pink part of this slide, then you understand what I'm about to say next. Because when you send kids to me, what I spend the majority of my time arguing with insurance about is not like the Star Trek whole exome sequencing, you got to pay every penny of this $6,000 study because this will give me my answer. It's not, I'm not even talking to them about that. I don't even bother with that, right? I talk to them about, again, the low-hanging fruit. I want to go after the studies that up to 30 or 40% of the time are going to give me my answer, okay? That's what I want. And I want, because I believe that it's either going to be an extra or missing chromosome problem, or it's going to be a single gene disorder that's been deleted or duplicated. So I do 2 studies typically, a chromosomal microarray and a karyotype. Everybody probably remembers karyotype, right? That's just counting the chromosomes, making sure they're all there. The structure looks fairly good, right? But I want to give you a little more insight in what I mean by a chromosomal microarray, okay? So everybody take a deep breath. Okay, just you might love this, you might hate it. I don't know, we'll see. I'll wait to get your evaluations. Comparative genomic hybridization means comparing 2 genomes using DNA hybridization technology. All right, here's a game. We're going to play a game. It's going to be awesome. The patient genome's on the left. The reference genome is on the right. Tell me who can spot any differences in these pictures. Yeah, go ahead, shout them out. What do you got? Oh, this poor guy disappeared. You said there's a little girl. A little girl where? That poor girl she disappeared over here. The rectangles became squares. Where's that at? In the middle. Got it. TVs. So you're seeing changes, right? They're not obvious. You have to really look, right? And there's a few others, like this girl's actually here. This lady doesn't have any shoes on now. Like, that's just gross, right? But the point is, it's like, this is what a microarray does. It takes a person whose genome is known and sequenced through the Human Genome Project, and it compares it to your patient that you've sent to old Doc Noble, and he compares the genomes to try and find where the differences are, okay? And by differences, I don't mean mutations, like, oh, this is an A and it should have been a T, or this page is missing. I mean, man, this poor guy is doubled up and he should only be one person. This lady's wearing shoes here and she's not supposed to be, right? Which is weird in and of itself. But this, this poor kid is missing, which actually she's right here, but it's just interesting, right? So that's what that's what I'm doing. And here's how we do it. We take the patient's DNA and we stick it with greens. We take what's quote-unquote normal or typical DNA and we stick it with reds. And then we hybridize them. We stick them together, right? It's like this 8th grade dance. We just stick them all in there and just make them get along, right? And we create a picture. And the picture, when things are balanced, reds, right? Reds and greens kind of make a yellow. And that means they're balanced. Reds means, somebody doesn't have a partner, and they should. Greens means, somebody brought their friend and they weren't supposed to, right? So that's what it means. That's what a comparative genomic hybridization does, okay? And it really is a beautiful, beautiful technology to help me detect what are called copy number variations, meaning I got too much stuff here or I've got not enough stuff here and it's bad. Something bad has happened. But where it's all going is exome sequencing. All right. Now, this is going to compare technologies. Here, what we have is the near perfect resolution, meaning here's how it's supposed to look. Here's what our patient has. And we found all the differences because we sequenced the whole thing, all 3 billion nucleotide. We just did it all. And now we know exactly what the differences are, right? This is where it's going to go. This is where it's going now. OK, this is where it was. OK, people say, well, Dr. Noble, why don't you just do a karyotype? Can't you just detect all that? I'm like, well, okay. Here's what now remember the analogy that we've been utilizing. This is how a karyotype compares. Remember the example of how they were different? This is about all you can detect with a karyotype. Is big differences. Oh man, I didn't have a dude and now I had one dude, now I've got 2. And this TV was off and now, or it's on, now it's off, right? Those are like big ticket changes, 10 megabase, 4 megabase changes. Millions and millions have to be missing or changed before you get to see it, right? It's like flying over a city and deciding if your favorite restaurant is there. It's kind of hard. Here's what people say, oh, Doc Noble, maybe you should just do that fish study. People love to do this. They love to call and say, yeah, I'm thinking about doing a fish. And then I love to say, awesome. What are you going to fish for? Because there's 3 billion nucleotides, and if you don't know what you're fishing for, I don't really know what we're talking about here, right? Because fish is just looking with a flashlight at an area of the genome that you think a problem lies, right? So you look here, and it's either there or it's not there. But look at all the black space. You're not looking there at all, right? So a fish is only as good as the person fishing. This is a microarray. This is how it actually compares. You can see it's not perfect, but you catch a lot of big ticket things. It's still grainy. It's still not perfect, but this is pretty darn good. Here's the problem. I always tell families, I'm like, yep, I don't usually draw blood the first time I see him unless I really am worried about something, because the bottom line is I can spend $2,000 just by walking into the room, being like, if I draw blood, it's $2,000, friends. Bam! Right? That's for the microarray. Karyotypes about 500. Sequencing panels of multiple genes, 5, 6, 9 grand, right? This is why insurance hates it, because this could potentially be 17% of the population that could benefit from these studies, right? I want to close in the last 5 minutes with a few basic remarks about why a diagnosis matters, okay? I'm going to summarize it. I think the easiest way I can summarize it is that it provides us with a number of things that we can anticipate for the future. Not only can I quantify recurrence risk in a family, but I can also anticipate problems like the train's going to come off the tracks at 15, or this kid is going to lose their hearing by 11. And so we need to click into different types of mechanisms to make sure we head those off at the pass. So the thing you have to think about with diagnosis is, what kind of person are you? You've done what I've told you. You've detected the things. You've done the evaluations. You're either going to refer them or you're going to try and work them up. Option A is what most people do. They just refer and wash their hands of it. And I don't blame them for that. Option B is they'll conduct testing, and they'll only refer when they have abnormal results. What I would say is that it's difficult for me to convince insurance to pay for option B. I'm not sure you're going to have a lot more luck with that. But if you want to try, please call me. Because if they have Title 19 insurance and you're of the mindset that they're just going to write it off, those days are gone. That family will get a $2,000 bill in the mail. Because I'm sure your institution is not any more altruistic than Unity Point Health. And we say, all right, well, it wasn't a covered expense and we did it, so sorry, right? So proceed with caution. Please call me with these kinds of questions, because I lament that. A few basic things on treatment I alluded to. Pharmacogenetics. Who gets 6-mercaptopurine? Who gets Coumadin? Who gets warfarin? And at what dose? These are all things that genetics are touching base with that are going to help us know who's going to respond to what. All right. Last few things that I want to close with. The misperceptions about genetic testing is that it doesn't matter. Right? Insurance won't pay. There's no treatment. It's only for adult conditions. Blah, 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 blah. Genetic testing in genetic disease doesn't matter. Like, this guy doesn't need to know that this is coming right here. Right? Like, I would want to know that if I was in this boat. I'd be like, yeah, let's go ahead and go the other way. Let's turn this around. Right? Now, these kids can't get healed per se for most of these conditions, but man, it's nice to know that their risk of developing diabetes in their teen years is exponentially higher than everybody else's, right? Or that they should really have their kidneys looked at. This is again for your reference, but it's important for you to know there's legislation that protects people against being segregated against if they have a genetic condition. Health insurers, by and large, can't do this. And this is because of the Genetic Information Non-Discrimination Act. They can't screen you for genetic conditions. They can't abstain from giving you the kinds of services that you need because of a genetic condition, but that doesn't apply to a few basic things: life insurance, disability, and long-term care. So when we would do genetic testing on people at the university, Huntington's, spinocerebellar atrophy, and they were starting to show symptoms or they weren't sure and they were 18 or 19, we would say, stop, go get life insurance. Get as much as you can. Just go, and then come back. all right? Or know that you can't, once we go forward with this, we are not going to help you commit fraud. Like, we're not doing it. If you know ahead of time that you've got this condition, you have to tell these organizations about it. Otherwise, it's fraud. The ethics of genetic testing can be summarized very quickly. We almost never do genetic testing on children less than 18 if it's an onset condition, right? They're not planning on having a family anytime soon, at least we hope. Unless it's an early onset condition, like early onset Huntington's, we don't do it, right? And when and if we did, there'd have to be certainly informed consent based off the age of the child. So that I can easily summarize that. Here's the last slide I want to show you, okay? There's 10 resources I put together for your review that I think could be particularly helpful if you're interested in genetic medicine or you're caring for children who are complicated. OMIM is free. These are all free. OMIM, which is Online Mendelian Inheritance of Man, the website's there. That's a great place to go to search for single problems like low set years or white spaced eyes. And you can mesh terms together to do like a search to see which disorders could kind of potentially come up. It also gives you a nice clinical synopsis. Gene Test is the second one, and there's the website. It's like up to date for geneticists, and it's free. It's constantly updated. It's written and updated by the best people in the world, and it costs $0. Right? You can cut and paste, which is awesome. It's just a great website. And these others here are for your review. Here's the Genetics and Primary Care Institute is also a great resource as well, which I've referenced. Here's my citations. And then this is the point where I stop for questions.
You probably get this every talk, 23andMe.
Yeah, yep. Consumer-based genetic testing is fraught with problems. These studies are typically single nucleotide polymorphisms. So typically what they're doing is they're looking for, does old Doc Noble have a C, a T, an A, or a G in this specific place? Because if he does, we've developed a system that says that the odds ratio that he's going to go on to develop Alzheimer's is 1.5. So, 1.5 times higher than the general population, right? So, but it's not like it's actually a mutation that they're testing. They're testing a single nucleotide polymorphism that's been associated with those findings, okay? So it's, from my perspective, it's fraught with errors in regards to how it's interpreted, and you have to understand these organizations don't really care if you feel good about your results. So I would say I've had colleagues do it just to see what it is, but I wonder what it is you're after. I think there's probably a question underneath the question, and I'd be like, "What are you worried about?" You know what I mean? It's a fair question, but it's as good as I got. Anybody else? Kind of get it all figured out? Good. A little rushed at the end. I apologize. Ames is apparently moving farther away from Des Moines every time I come here. It's like it takes me longer. It's my own fault. But thanks for coming. Thanks for your referrals. Thanks for the good job you guys do.